Welcome, everybody. My name is Marianne Hart, and I'm the director of the Graduate Program in Health Administration at Regis College, and I'm going to be your moderator tonight. Welcome to Building Back Better, the Future of Healthcare. We have a fantastic group of presenters tonight, and I want to extend our warmest welcome to you, the audience, and to them on behalf of Regis College. This is actually our March annual health reform event, which commemorates the passage of the Affordable Care Act in 2010, also known as Obamacare. Tonight, our presenters will discuss ongoing health reform efforts on the federal, state, and local levels, 12 years after the passage of the Affordable Care Act. They will give examples of policy and program initiatives designed to expand access to care, contain costs, improve quality, and achieve equity. They will also discuss the challenging politics of achieving these goals. Throughout their presentations, you will see how addressing the social determinants of health and the integration of behavioral health into healthcare is both building back better and also the future of healthcare. But before we get started, I have a few housekeeping items to attend to, and then I will introduce our panelists. Could I have the next slide, please? If anyone in the audience is from the media, we welcome you, but please send a direct message to Kayla Bavin in the chat, letting her know who you are and who you represent, so we can let our speakers know. Next slide, please. A few important reminders. In order to receive contact hours or class credit for this evening, you must stay until the end, and that includes the question and answer period. At the end of the program, for both CEUs and class credit, you must click on the link on the evaluation form, which will be put into the chat, and you must include your name. If you just want class credit, include the name of your faculty person on that form as well. Next slide, please. Faculty will be notified of your attendance, and CEU certificates will be emailed to you in 7 to 10 days. If you are not requesting contact hours or class credit, we hope you'll still stay and fill out the evaluation form. This guides us when we plan future programs. And that link will be in the chat until 8:45. So don't leave until you fill out that form. It will be posted in the chat, at 8:25, and I think it will be there to 8:45. Next slide, please. You might have noticed that all attendees have been muted. We ask that you stay muted throughout the program with your video off. Anytime during the program, you may submit questions to everyone in the chat. However, they won't be answered until the final Q&A session, which is the last 25 minutes of the program, from about 8:05 to 8:30. During the Q&A session, we ask that you send your questions to Kayla Bavin in the chat. If we have time left, you may also ask questions at the end by raising your hand. But if you're called on, don't forget to unmute yourself. We hope you're comfortable doing this because the Q&A session is really one of the highlights of the evening. Now, before I take up too much time, I'd like to introduce our speakers. The first one, and this is the next slide, please, is Dr. John McDonough, Professor of Public Health and Practice in the Department of Health Policy and Management at the Harvard School of Public Health. He's also the Director of Executive and Continuing Professional Education. He brings with him 37 years of experience in government and education, and he served 5 years as Executive Director of Healthcare for All here in Massachusetts, 12 years in the Massachusetts State Legislature representing Jamaica Plain, and 2 years as a senior advisor on national health reform to members of Congress. His accomplishments are relevant to this evening's panel include the key role he had in the passage of the 2006 Massachusetts Health Reform Law and its subsequent implementation, and his work and development on the passage of the Affordable Care Act in 2010. He publishes extensively, is author of 3 books, including National Health Reform 2011. We're most fortunate to have him here as a highly regarded expert in state and federal health reform. Advance to the next slide, please. Our second speaker is State Senator Cindy Friedman, who has served in the Massachusetts Senate since 2017. She represents the towns of Arlington, Woburn, Billerica, Burlington, and part of Lexington. She has previously worked as a public school teacher as well as an executive in a high-tech industry. It is this diversity in her background as well as her values that have helped shape the issues for which she advocates and sponsors legislation. Most recently, she played an instrumental role in legislation to protect people from the devastating impact of COVID-19, including helping small businesses and the homeless. She has sponsored legislation to require insurance carriers to pay for telehealth services and protect patients from surprise medical bills, legislation to eliminate barriers to behavioral health care for children with complex needs, and legislation relative to mental health parity implementation. She also was a key leader, listen up, you NPs in the audience. She was a key leader in removing a barrier to practice for advanced practice nurses. Physician supervision was removed through her efforts just a year ago. More recently, she has led on legislation that tackles the growing cost of pharmaceuticals and legislation to strengthen the behavioral health workforce. She will talk about some of these initiatives tonight. Her impact as a Massachusetts state senator was recently recognized when the Women's Bar Association honored her with a 2022 Public Official of the Year award. We in turn are honored to have her this evening. Next slide, please. Our third guest is Dr. Monica Bharel, a primary care physician at Boston Medical Center, who currently serves in the newly appointed position of Senior Advisor to Boston Mayor Michelle Wu. Prior to her current position, she was Commissioner of the Massachusetts Department of Public Health, and before that, she served as Medical Director to the Boston Healthcare for the Homeless program. In all her roles, she has been a champion of innovative policies and programs that have increased visibility, funding, and support to advance social justice, equity, and opportunity for underserved populations. She's currently leading Boston's efforts to address the intersecting crises of substance abuse disorder, mental health, public safety, and homelessness, most recently in relation to resolving the challenging situation at Mass and Cass, which she will discuss tonight. As described by Dr. Bharel, the crisis requires a coordinated response from government service providers in our community. She is here this evening to describe that local response. None of our speakers this evening or members of the Planning Committee have noted a conflict of interest with regards to the topic being presented. And with that, Dr. McDonough, I'm going to turn the program over to you and to your slides.
Okay, can you hear me? Am I coming through? Okay.
Yep.
I want to share my screen and see if that works okay. Can you see this? Is this coming through, everybody? Yeah.
Yep. Coming through, it looks good. Yeah.
All right. So first of all, I just want to say it's a pleasure and honor to be here with folks from Regis College, particularly Mary Ann Hart, who I've known for a long, long time, And it's a real honor and pleasure to be here with Senator Friedman and with Dr. Bharel, who are dynamic and important health policy figures right now in Massachusetts, in Boston. And I look forward to hearing both of them. So I'm honored to be here with them and with all of you. And I was asked to, okay, I need to be able to advance my slides. Here we go. Okay. I was asked to talk about US health reform and what's going on. So just a little bit about where we are right now, just to place things, then walking back a little bit to draw from some key elements of the Affordable Care Act that are of particular importance today, then describe a little bit about the American Rescue Plan Act, otherwise known as ARPA, which was passed and signed into law in March 2021, just a year ago, and did some highly important things that people need to understand better, and I'll explain. And then I'm going to talk a little bit about the Build Back Better plan, the legislative initiative from President Biden that passed the House and has run into roadblocks in the Senate. And so just a little bit about what's in there pertaining to health policy and what its prospects are. And then looking forward, 2023 and beyond. So that's what I intend to do, and then really look forward to the questions. So where are we right now, the evening of March 9th, 2022? So a little bit about what's going on. So just for context, the Affordable Care Act was signed in the year 2010, March of 2010, so coming up on its 12th anniversary. And for most of the past decade, in fact, for just about all of the past decade, the major effort on the part of Republicans was to repeal the law or repeal and replace it. Major effort in the first year of the Trump administration, 2017, that fell short, and repeal and replace is now pretty much over. It's not going to happen. There have been 3 major cases that went all the way to the Supreme Court. The Supreme Court has turned all 3 down by increasing margins. And so it feels like the ACA is increasingly settled policy as it continues to evolve and change, and repeal and replace are over. The Republican lawsuit to repeal it died last year. Democrats and the Biden administration are promoting new reforms and continuing to press them to strengthen and improve the ability to get private health insurance on the ACA's marketplaces, also known as exchanges. There's a big effort to try to help 2 to 3 million low-income folks in 12 states that have not adopted the Medicaid expansion as permitted under the ACA. Big effort on trying to control the prices of prescription drugs on a national basis, and talk about adding some additional benefits to Medicare, but nothing more than that. And I'll talk a little bit about that if I have time, the public option, Medicare for all, so forth. ARPA was a game changer for the ACA because of the ability it had to make the subsidies to be able to buy health insurance more affordable. And it has had major positive impact for millions of Americans who rely on the marketplace, although the benefits are time limited. And they end on December 31st this year, unless Congress extends them. That's part of the Build Back Better plan that is now stuck in the Senate. It's highly important that it happen. Other important thing, so the economic downturn connected with the COVID-19 crisis was the first time since the ACA was signed that we went through a big economic downturn. And it was a testing moment for the ACA structure, because in every other downturn, as long as any of us have been around, when the economy crashes, the rates of uninsurance go up significantly as people lose health insurance, as they lose their jobs. And so the COVID-19 economic crisis was really the first time that we went through this process and did not see that happen. So significant testing for the ACA, and it worked. And the last thing I'm going to talk about is the so-called value-based care agenda, trying to move health policy, health finance, and health delivery away from a fee-for-service system that's based on the quantity of services provided toward value-based care, rewarding providers for the quality, efficiency, and effectiveness of what we do. We're now 12 years into that experiment. I'm going to talk a little bit about it. It's not going away. It's here to stay, even though the results from it thus far, I'd say, to be generous, are mediocre. All right, let's get into just a little bit about where we are right now in the system. We have been, for at least 40 years, the most expensive healthcare system in the planet, and we continue to get expensive. This is healthcare spending on, oh, that should be per capita, not per capita. Sorry about that. Doing these things too quickly. But you can see that the United States at over 10,000 per person is nearly twice as much as the second most expensive system, Germany's, which is under 6,000. The median is under 5,000 in terms of advanced economies. So the major feature of the US system, which is how much we spend, continues to be the most important feature in terms of what stands out. Here's another chart that looks at US health spending as a percentage of gross domestic product going all the way back to 1980. And so if you go back to 1980, the US is that top line, that red line. And if you go back to 1980, you can see we were the most expensive and very much in the pack of all of these advanced nations that are listed over on the right hand of your screen. I hope you can see that. And what you can see is starting in the 1980s, we started to separate from the pack. And you notice all of the countries continue to go up, but none of them went up at the rate that we see in the United States. And the distance between the US and all of these other countries over these 40 years has just grown wider and wider and wider. Meanwhile, all of these countries cover all of their citizens and provide care that is at least as good as what we find in the United States. This is a study that's done by a great healthcare foundation in New York City called the Commonwealth Fund. This is their 7th time doing these apples to apples comparisons between 11 leading advanced nations, including the United States, on access to care, care process, administrative efficiency, and equity. And you can see at the top of the chart that it provides a overall ranking for all of the systems put together. And you can see, if you can get over to the right-hand part of your screen, you can see the US comes in 11th out of 11. We have overall a significantly underperforming system in terms of access. Care is where we do better, what happens inside healthcare settings, but then we go way down on administrative efficiency, equity, and healthcare outcomes. And so this is, again, one of the features that drives the continuing efforts to try to reform the US healthcare system. And here's just one example. We like to think that things are, even if things are not where they should be, we like to think that they're getting better. We go back to the 1980s again, we look at maternal mortality in the United States and the trends, and we see a starkly deteriorating system that has just been getting worse in ways that are of staggering impact in terms of people's lives in the United States, our fellow citizens. Anyway, a little bit of background on the system. We can talk about it in terms of whether you think these are the right things to look at or not. But these are some of the features that stand out. Just want to show you a little bit about the Affordable Care Act, passed in 2010. This is the basic core outline of the law. Just like a book is divided into chapters, a federal law is divided into titles. The title is just the name for the chapters of the law. There are 10 titles of the ACA, and I'm just going to draw your attention to the most important ones that have been the most difficult and the most controversial, and also the most impactful. Title I, which absolutely was a revolution in terms of private health insurance, particularly for individual coverage. Title II, which engineered a major expansion in the Medicaid program, and Title III, which did important changes to Medicare, and also importantly is the home of the value-based care revolution in terms of what the ACA attempted to achieve. So just keep your eye on those three: Title I, private health insurance; Title II, Medicaid; Title III, Medicare and delivery system reform. The rest of them matter, but we don't have time to go in there, and these are the three key ones. Just a little bit of description of these three. Title I, private health insurance. This created for the first time a vehicle for people who were not at the poverty level, who are above what's either 100 or 138% of the federal poverty level, could buy through state or federal health insurance exchanges subsidized private health insurance coverage for themselves and their families, and done so at a rate that made the cost significantly less expensive. The ACA's insurance made available under Title I was significantly more affordable than what came before, and not nearly affordable enough for what many Americans needed in terms of financial support. So, so the ARPA law made some significant changes to it. I'm hearing some typing that's kind of loud. I'm wondering if that person could put on mute, please. And then the other important piece is Title I made it illegal for insurance companies to make coverage available only on the condition of looking at your personal or family medical history. A practice known as medical underwriting was made illegal. A fundamental change in the business of health insurance that took effect on January 1st, 2014. Increasingly, people don't even remember and take this new way of doing things as the way it's always been, but it's much more recent than that. Title II with Medicaid, for the first time, made Medicaid available for all low-income households in the United States. That's how the law was written. However, in the 2012 Supreme Court case on the Affordable Care Act, the Supreme Court upheld the constitutionality of the law, and at the same time said the Medicaid expansion in Title II had to be an option for states rather than a mandate. And as of today, there are 12 states, mostly in the Deep South in the southeastern United States, that have refused to expand. And there's continuing efforts to try to figure out ways to get coverage for those very disadvantaged populations. And then Title III particularly moves to a series of mechanisms to create value-based payment. So we reward providers for doing the right thing as opposed to not the right thing. This chart just displays the popularity or the unpopularity of the ACA. You can see the orange line is unfavorable, the blue line is favorable. For most of its life, for the first 6 years, it was distinctly unfavorable or up and down. And starting in 2017, for the first time, it has become much more favorable than unfavorable. There's still a high favorability level, but the perceptions of the law have changed. And I think not coincidentally, that's because of the efforts in 2017 by the Trump administration and the Republican-controlled Congress to try to repeal the law and never be able to present a satisfactory alternative. This just shows the change in terms of the numbers of uninsured Americans and the rate. The numbers are in millions, so we're high from up near 47 million in 2010 down to about 28 million. So a significant drop, the lowest it's been since we've been counting. And we still have a significant number of people who are still uninsured. This is another way of looking at the rate of the increase. The earlier slide I just showed you was of the uninsurance rate among everybody under age 65. This shows the rate among everybody, including the elderly. And so you can see we've gotten the rate of uninsurance down to around 8%, which again is the lowest rate since we started counting in the early 1960s. This is a map that just shows where are the uninsured. Yellow, lighter yellow means lower rate of uninsurance, and a darker color means a higher rate of uninsurance. You can see Texas, for example, and Florida, two states that have adamantly refused to expand Medicaid, really stand out in terms of high numbers. More people are uninsured in terms of numbers and volume in Texas than in any other one of the 50 states, okay? And let's just talk a little bit about the value-based agenda. This is taken directly from the actual law itself. By the way, if you're ever interested, just Google Affordable Care Act text and poof, it will show up on your screen. But this is Title III, as we mentioned, and you can see the name, Improving the Quality and Efficiency of Healthcare. One of the key mechanisms that we did in terms of Title III is establish a new entity called Accountable Care Organizations, first in Medicare, now in Medicaid, and increasingly in commercial insurance, where providers, instead of just getting paid for how many procedures they do, actually are now held accountable for the value, meaning the quality and the efficiency of what they do. So we can see this has become a significant part of the American healthcare infrastructure since the ACA became law. And this just shows a little bit about the changes in terms of the Medicare program. So you can see the whole pie right now. It's about 60 million to 65 million now in 2022 as the baby boomers come on board. Used to be that we had two main parts of Medicare. The lighter blue was traditional Medicare or fee-for-service Medicare, and the darker blue is called Medicare Advantage, which is when instead of just getting services directly yourself, you get it through a private health insurance company. Medicare Advantage has been growing enormously and quickly, and now represents closing in a couple of years about half of Medicare enrollees. And you can see the 21%, those are people in the ACO world who are still part of traditional Medicare, but they actually resemble Medicare Advantage plans. So big revolution going on now. I'm running out of time. I'm going to have to go quick. This is the big change in the federal ARPA law that it did that's important in terms of the ACA. It took the level of subsidization that was available to people and it changed it. It significantly lowered it. So if you look at, for example, 150 to 250% of poverty over on the left, the prior law was the ACA, and the prior law said if you were 150% of poverty, which is under 20 grand for a single adult, you still had to pay between 4.4 and 6.5% of your household income in premiums. You can see what ARPA did. It brought it down to between 0 and 2%. It also changed it before the ARPA law. People who were over 4 times poverty, which for a family of 4 is about 100 grand, which sounds a lot, but when the price of health insurance is like $25,000 for a family coverage, it's not that great a deal. So you can see for the first time, those folks have now been part of the law and they can get help as well. I'm going to skip over. This is just a little bit about the changes in terms of who's been advantaged. The light blue represents the changes from the ARPA law. Significant change, the most important change since we created the law. So big fight now in terms of whether these subsidies, which have helped millions of people afford health insurance coverage designed by the ACA, will continue beyond the end of this year, is one of the major issues in Build Back Better. And both of the Democratic senators who've had problems with the Build Back Better legislation, Senator Manchin from West Virginia and Sinema from Arizona, actually support this measure. So Build Back Better, what was in it? So here's a list. And I understand you all have these slides, so you can look at these things, but these are the proposals. continuing the subsidy expansion for an additional 3 years, adding a hearing benefit to Medicare, putting significant controls on prescription drug prices and spending, capping out-of-pocket spending in Medicare Part D, the prescription drug part, filling in the Medicaid coverage gap in the 12 expansion states, making major advances in addressing maternal mortality, capping Medicaid for the territories, funding family and medical leave. You can see the cost of these. So significant policy changes up for grabs. Let's look ahead. So what's coming up? In spite of the dour outlook, negotiations are going on Capitol Hill with Senators Manchin and Sinema and others to see if there's a pathway to get something through the Senate. We have the midterm elections coming up in November. All things being equal, in the first midterm of a new president, the president in power tends to lose control of one or both houses. So if history prevails, then the Democrats will lose control of the Senate and or the House this coming year. And all things are not equal because of COVID-19, January 6th, Ukraine, the economy. Importantly, the public option and Medicare for all are not on the table at all. This is my last, I'm going to show just 2 more slides, why Medicare for all is so difficult to happen. This first chart shows you the presidents who tried to do major advances in coverage in the United States, going from Harry Truman up to Barack Obama. And the date is the date when their effort either won or lost. The White House party, the only Republican who tried to do it was Richard Nixon in 1974. And in most of these, Democrats had unified control of Congress, except for in 1997, when Clinton attempted to pass the Children's Health Insurance Plan. And then I'm going to fill in these other 2 columns. What did they attempt to do and what happened? And so what you can see is whether or not their policy ambition was comprehensive or incremental. And so Harry Truman tried to change healthcare for everybody all at once. So did Richard Nixon, so did Bill Clinton. And you can see in the next column that all 3 efforts lost. Lyndon Johnson trying to pass Medicare and Medicaid, Bill Clinton passing children's health insurance, and Barack Obama passing the ACA, all were clearly incremental. They didn't try to cover everybody, and those 3 won. And that is why doing health insurance, universal health insurance, is so darn difficult, because it is just not in the nature of the American political system to be able to accept revolutionary change in the healthcare system. At least it hasn't been for the past 72, 73 years. And we see that trend continuing right now. I will stop there and look forward to questions. I'm sorry I ran over for about 5 minutes.
You were actually just fine, because we get started a little bit earlier than planned. I want to thank you for your presentation. And also, I forgot to say in the introduction that we use John's class, a massive online class. We use a lot of his lectures in the health policy class that I coordinate. So some of you in the audience might recognize him from those lectures, and we've really appreciated having access to those materials. So thank you very much. Our next speaker is Senator Cindy Friedman, and we look forward to hearing what she has to say about Massachusetts.
Thank you. Thanks, Marianne. Hello, everyone. Just need to get my technology here up and running. Okay. Thank you all. I'm happy to be here tonight, and I'm very, very honored to be included with 2 such distinguished leaders and champions in the healthcare space, Dr. McDonough and Dr. Bharel. So thank you for letting me be part of this august panel. So for those of you who don't know me, I'm State Senator Cindy Friedman. I represent the 4th Middlesex, which goes from Arlington to Bill Ricca, and I am also the co-chair of the Joint Committee on Healthcare Financing and vice chair of the Senate Committee on Ways and Means. Of course, we're here to talk about healthcare, and for my part, I've been asked to talk about Massachusetts initiatives to improve healthcare access, cost, quality, and equity. My focus is going to be on the current legislative session, which runs from 2021 through 2022. And I'm going to focus on that because there's some big things going on in this policy space right now. Next slide, please. So I'm going to talk about past and pending, past meaning legislation that we have passed and legislation that is pending in this current cycle. I'm going to talk about next steps, and then I'm going to talk about a call to action. And I just need to stop and thank I know there are many, many healthcare professionals on this call, and I would be absolutely remiss if I did spending. So that is the total of our healthcare spending. Our healthcare spending per capita ranks near the top among the states. Dr. McDonough showed you the United States. This is in Massachusetts. The average cost of an insurance premium, just the premium, not the co-pays, deductibles, for a Massachusetts family is about $21,000 a year. That's tripled from 2000. The average household income in Massachusetts for a family of four is about $80,000 a year, okay? Doesn't include rent, doesn't include food, doesn't include education. It's expensive, and we really need to pay attention to that. Next slide, please. So as you know, the Federal American Rescue Plan, which is ARPA, included nearly $5 billion in economic stimulus funds for Massachusetts. And last December, the legislature passed a bill appropriating about half of those funds. Because we've been in the midst of a global pandemic that necessitated these funds, the ARPA bill that we just passed rightly and understandably dedicates a fourth of its funding exclusively to healthcare and human services. I've included the largest healthcare spending categories in this slide, but if you also add the local healthcare earmark spending, the total spent on healthcare services in the ARPA bill exceeds $1 billion. So for the largest categories of spending, the bill included $400 million for behavioral health services, which includes $122 million in a loan repayment, recruitment, and retention initiative to help respond to the workforce crisis. It included a $200 million behavioral trust fund that we can use to further that workforce. There was $15 million for a successful police co-responder model where social workers and other mental health workers go out with police to respond to mental health and substance use calls, and about $5 million for an ED boarding portal that it would be there to help with emergency room personnel finding beds for people who need mental health treatment. There was also $260 million for hospital relief, which has now been allocated, with 90% of those funds going to high public payer mix hospitals and hospitals experiencing the most financial stress due to COVID. There is $200 million for long overdue public health infrastructure updates, and another $50 million for nursing home workforce and quality of care facility improvements. And I want to remind folks that the state still has another $2.3 billion in ARPA money left. So we're now looking at the best ways to allocate those remaining funds, and there's no shortage of worthwhile initiatives. Next slide, please. So I want to talk to mental health, addressing barriers to care. So despite the transformative investments in healthcare through the ARPA funds, there's still significant barriers to care, especially mental health care, barriers that have only been heightened and exacerbated by COVID. COVID has revealed what many of us have known for years. There is a severe crisis in access to and delivery of mental health care. Years of ignoring the importance of mental health care and carving it out as if it exists solely by itself, detached from any other part of healthcare, has resulted in a broken system that has and continues to leave many without the critical treatment they need and deserve. and this is especially true for children and adolescents. This, in addition to insufficient rates for mental health care providers, insufficient number of providers, the completely unnavigable and totally unfriendly, unconsumer-friendly insurance system we force people to confront to find care, and persistent stigma surrounding mental illness has created a system that serves few and is unavailable to many. An act addressing barriers to care for mental health, or the Mental Health ABC Act 2.0, which passed in the Senate and now sits in the House, works to craft a system that's more accessible and more equitable and meets the needs of patients who require care. Next slide, please. One of the most important measures we take to ensure equitable access is to achieve true mental health parity. And this has been the law of the land at the federal and state level for decades, and yet in practice, it's not enforced. So this bill provides the necessary tools to enforce parity. And it, for example, it directs the Division of Insurance and Mental Health, the Division of Insurance and Mass Health to require more robust reporting requirements and stiffer penalties for non-compliance of the commercial carriers and mass health contracted entities. We also put restraints on the use of medical necessity criteria and eliminate prior authorization. We must not allow insurance carriers to impose restrictions on providers' clinical judgments in terms of prior approval and concurrent review requirements for mental health services, which is what happens today, every day. And we cannot talk about mental health care without recognizing the urgency and severity of the state's emergency department boarding crisis. This bill proposes a multifaceted approach to address this urgent issue, creates a portal for real-time bed search by emergency room personnel, and it establishes a complex case resolution panel to intervene and help resolve barriers to care for children with complex behavioral health needs that are experiencing long boarding times. And long boarding times are months, weeks and months. And the bill requires all hospital EDs to have a qualified behavioral health clinician available 24 hours a day or during all operating hours. There are many more proposals in the bill that would ensure equitable access to mental health care, but I want to make sure right now that I emphasize that none of these proposals are possible without also supporting the mental health care workforce. And I'll talk about that next. Next slide, please. So there was a healthcare workforce crisis before the pandemic, and that crisis has persisted and been exacerbated by the pandemic. We must address the workforce of today and tomorrow and reduce the barriers folks face to do this work. This includes leveling the playing field for reimbursement to mental health providers by requiring at the very least an equitable rate floor for evaluation and management services that is consistent with primary care. And I want to point out here, that is not a high bar because we don't pay our primary care providers very well, but we pay our mental health providers even less. And it includes raising rates paid to those that work in our community-based settings, community health centers, and inpatient behavioral health hospitals. I strongly believe that if we invest our time, money, and energy into reforming our delivery of mental health services in the Commonwealth so that they truly meet the needs of patients and the needs of the workforce, then we can ensure that more patients get the care they need, end the criminalization of mental health, and save the state money, most importantly, save lives in the long run. That's why this bill is so important. Next slide, please. So in addition to mental health care reform, a clear and very important next step in creating a healthcare system that delivers affordable, high quality, and accessible care to all our residents is to focus on reining in ballooning prescription drug costs. Prescription drug reform matters because prescription drug costs are rising to the point of unaffordability for many, causing them to forego or ration their medication, which leads to worse health outcomes and increased costs to the state. Currently, there's little state oversight of the pharmaceutical industry or ability to collect data on how prices of prescription drugs are determined or how pharmaceutical costs impact the state's healthcare market. An act relative to pharmaceutical access, cost, and transparency, also known as the PACT Act, which was recently passed in the Senate and also sits in the House, takes a comprehensive approach to address the high and rapidly increasing costs of prescription drugs for consumers and the healthcare system as a whole. Next slide, please. The PACT Act contains enhanced accountability tools to address high cost and patient access issues to certain drugs that meet a high price threshold or are deemed essential public health drugs with a significant price increase. It allows the Health Policy Commission, the HPC, which oversees healthcare costs in the Commonwealth, to engage with manufacturers to work to bring those costs down when the cost of the drug is found to be out of sync with the value. Additionally, the bill provides immediate insulin price relief by limiting out-of-pocket spending for residents by permanently capping copays at $25 per 30-day supply and eliminating deductible and coinsurance requirements. Insulin is an essential prescription drug, and frankly, it's unconscionable that we force patients to pay exceedingly high amounts to access a drug that they simply cannot live without and that's been around since 1922. Next slide, please. In addition to prescription drug access and cost improvements, the PACT Act provides more transparency and oversight tools by including pharmaceutical manufacturing companies and pharmacy benefit managers, PBMs, in the annual healthcare cost trends hearing conducted by the HPC and the Center for Health Information and Analysis, also known as CHIA. This allows us to better understand the role of pharmaceutical manufacturing companies and PBMs in driving costs within our overall healthcare system. PBMs act as brokers or middlemen in the drug transaction process, play a major role in determining drug costs, and yet they are highly unregulated and very opaque. The bill creates a licensing process for PBMs, which will allow the state to directly regulate their activities and help ensure that PBMs are truly serving the best interest of consumers when they negotiate with pharmaceutical manufacturing companies and pharmacies on drug prices. So these are just some of the provisions of the PACT Act. The pharmaceutical industry plays an extremely important role in healthcare space. It is one that we absolutely value, we depend on, and we support. At the same time, the ability to buy needed medications is becoming more and more beyond the reach of our residents. We must bring these two realities into better balance, and I believe that the PACT Act 2.0 is the beginning of this process. There's a lot more to do. Next slide, please. So I've described some details on two of the major healthcare bills that have advanced in the Senate. So now it's worth mentioning another large healthcare bill that advanced in the House, the Healthcare Market Oversight Bill. I won't go into quite as much detail as I played no role in crafting this bill, but I will provide a brief summary and give you some reaction. The bill seeks to apply greater regulatory scrutiny over certain healthcare provider expansion activities. So right now we oversee mergers and acquisitions, we oversee new healthcare facilities, we oversee the ownership changes in healthcare facilities. There are two distinct regulatory processes in the Commonwealth that are part of this. The first is the DPH determination of need, or DON process. This authorizes DPH to review and approve a healthcare facility's proposal when they are going for capital expenditure and the other activities that I just named. There's also the HPC, Health Policy Commission's material change notice process, and this authorizes HPC to review and approve a healthcare provider's proposal for a new merger, affiliation, or acquisition by a carrier or hospital system. So some of the notable changes that Market Oversight Bill include is changing HPC to perform and update the state's health plan and healthcare resource inventory, and expanding HPC's authority to conduct cost and market impact reviews over certain healthcare provider expansion activities, which they currently cannot do. Requiring the DON process to take into account the effect of a project that will have on a nearby independent community hospital, and it requires them to look at the relevant HPC cost and market impact review. It also presumes certain consumer protections that are overseen by the Attorney General if the expansion results in or likely will result in a dominant market share for a healthcare provider, prices for services that are materially higher than median prices charged by all other providers in the same service in the same market, and a healthcare status adjusted total medical expense that is materially higher than the median total medical expense for all other providers for the same service in the same market. As passed, the House bill would affect existing DON applications. So I think some of you are familiar with the Mass General Brigham request for expansion. And in the House bill, that would cover that application. So a few reactions to this bill. One, I think that these two regulatory schemes, the DON and the market the market cost analysis process, are ripe for further reform. So I'm glad to see the House agrees. But two, I'm not sure that I agree with everything the House has proposed in this bill. For some of these proposed reforms, we'll be taking a close look at any intended or unintended consequences and whether we have all the safeguards in place for consumers and providers who deliver equal quality at a lower cost. And three, I think it's important that we use this and look at reforms that will engage us in a larger conversation about what authority we'd like to see HPC and CHIA carry in the future. It's been roughly 10 years since these two agencies were created, and it's time for us to take what we've learned from the past decade and reassess and reimagine how we can strengthen the tools for these organizations moving forward. Next slide, please. So I'll quickly go through the fiscal year 2023 budget. This is the budget that is before us now. In addition to funding healthcare services across the state, the FY23 budget will potentially include several impactful healthcare initiatives. And we can look at the governor's budget proposal to see some of them. First thing that the budget includes is a significant expansion of existing acute care hospital assessments. So right now we assess all of our hospitals, and we get from that assessment $417 million annually. And we use this to fund our Medicaid healthcare activities. And I'll go into that in a second. So the current assessment, we raised $417 million. The proposed expanded assessment would increase from $417 million to about $900 million annually over the next 5 years. So that is a huge increase in money available for mostly for public payer hospitals and for people, for entities that are that serve low income and uninsured people. Not every hospital gets assessed the same amount. There'll be 5 tiers, and based on where you fall, you will get a certain amount of that money. Safety net hospitals would experience a substantial net benefit from the assessment, as the payments made to hospitals from Mass Health through the assessment would exceed the amount assessed. So that means they would get back more than they put in. And if you include the matching funds that we get from the feds, this assessment would generate over $2 billion in funding annually. And that would go to targeted rate increases and payments related to health equity and clinical quality. It would go to primary care management and care coordination and health-related social needs. It would give money to our safety net provider, a trust fund for taking care of the lowest income of folks in our Commonwealth. And it would make payments for non-acute care hospitals for Medicaid payments, and these would go to eligible hospitals. And it would cover the health safety net, which is for low income, uninsured, and underinsured patients. The budget proposal also gives $170 million to implement the administration's behavioral health roadmap. And this is a new plan for delivering mental health services in the community. And that money would go to establishing community behavioral health centers. It would require a health payer assessment to help pay for 24/7 behavioral health access hotline and an urgent care and crisis intervention system, and $20 million for around $20 million for new DMH programmatic spending. It also extends Mass Health Supplement Drug Rebate Authority. We have saved over $100 million in pharmacy spending in the Commonwealth since we gave Mass Health the authority to negotiate drug prices. This would expand that to non-drug equipment, medical devices, and other drugs that aren't currently covered. And then the final thing that it does is it expands the Medicare savings plan by increasing Medicare income limits to 200% of the poverty level, up from 165%, to help lower the out-of-pocket costs for additional 35,000 low-income seniors in the state. And then the final bill that we would be looking at is the anticipated governor's healthcare bill. We hear it's coming, but we haven't seen it yet. What's likely to be in this bill is ultimately left to speculation, but we have an idea that it will include a lot of the initiatives that the governor filed in November of 2019, which we ended up not being able to take up because COVID got in the way. And there's pharmaceutical reform in there, there's primary care, behavioral health care expenditure targets, urgent care oversight, limitations on surprise billing, and the nurse licensure compact. Again, I'm not sure what's going to be included in this new budget, in this new healthcare bill, but we certainly look forward to reading it. Regardless of how we feel about it, it will provide yet another legislative vehicle that could potentially be used to pass important healthcare policy this session. Next slide, please. And then finally, a call to action. So I'm going to conclude with some steps you all can take if you're interested. And I truly hope you're interested, because we desperately need your voices, especially those of you that are seeing the struggles patients are facing every day in this process. First, I encourage you to learn more about the legislative vehicles I talked briefly about, and I've included the bill numbers so you can more easily find the latest versions. Second, I encourage you to engage with your colleagues around shared ideas and goals. What parts of these bills or initiatives do you like? What parts need improvement? There may be multiple concerns or points you would like to emphasize. Rank your priorities. Third, contact your legislators. I understand it may be intimidating to reach out to an elected official if you've never done so before, but we are people too. You are our constituents. So we are just trying to do what's best, and we cannot do that without hearing from you all. And lastly, talk to others who may be interested in this, whether they're in your field or not. The more people that are aware of the issues and are willing to talk to their legislators about it, the more likely your goals are met. Thank you very much.
Thank you so much, Senator Friedman. We appreciate all this amazing stuff that you're working on, and look forward to seeing what happens in the state legislature. That's certainly going to be one of the questions at the end. What do you think will happen? And apologies that we were a little slow with advancing your slides, your last few slides. You just had a technical problem, but
Okay.
we got through them anyway. Thanks so much.
Yeah, I'm sorry about that.
Also, just want to let you know that we have a tremendous number of psychiatric nurse practitioner students at Regis. And so they are very interested not only in the topic, but in some of the workforce issues they're facing. And I would also add, I think we have over 200 people on this Zoom session. So I think a lot of them are on there. But thank you very much. Our next speaker is Dr. Monica Bharel.
Thank you, Marianne. It's a pleasure to be with you all today. It is wonderful to be on this panel that is moderated by Marianne Hart, who I've done a lot of work with in the past. And I've learned a lot and really appreciated the comments of Dr. McDonough and Senator Friedman, both of whom I've worked with extensively in the past. So just thrilled to be here, and really appreciate all of the students. My dear colleagues are nurses and others who are on this seminar, in this call, and appreciate you being here. And especially for our students, I'm here because of you. I cannot wait to see what you're going to do to address all of the critical issues in health and healthcare that we have facing us. So now, if you need to, take a second and, stand up, take a shake. I know it's late in the evening, but also buckle your seatbelts, because I'd like to take you all of the information that Dr. McDonough gave us and that Senator Friedman gave us. Let's take it down now to an example. Let's take it to a real life example at the city of Boston's level and and walk that through. And I'll throw in a couple of references to what my colleagues have said as well. Before that, Marianne, thank you for that gracious introduction. To my colleagues on the phone, I am a primary care general medical doctor. I trained at the old Boston City Hospital. I've worked at many of our sites in and around Boston, including Mass General Hospital, Boston Medical Center, our neighborhood health centers, our VA system, and then for over 12 years at Boston Healthcare for the Homeless. And in that work, I have taken care of and had the amazing privilege of taking care of individuals who are sometimes in vulnerable situations that makes it harder for them to take care of their health and healthcare needs. Over my career, I've really expanded from thinking about what I could do for my patient in the exam room to the multiple factors that keep them from being able to take care of their healthcare or follow the instructions that I give them to take a blood pressure medicine or a congestive heart failure medicine. And that has led me to really broaden my view of health and what we as clinical people have a responsibility to our patients to do in the arena of health, and how that is a critical part of our responsibility. And whether it's from advocating at a clinic room or running a department of health, there's a role for all of us. From Boston Healthcare for the Homeless, I did go, as Marianne mentioned, to run the Department of Public Health, where I oversaw our work addressing the current opioid epidemic, which fentanyl is fueling an unbearable number of opioid overdose deaths, and then was at the front lines, as many of you were as well, of the for 2.5 years of addressing our COVID pandemic. And Build Back Better, when the Regis team asked me to present, I was eager to present because it's very important to me, and I know to many of you, that we do not lose the lessons that we've learned from COVID-19 and the ways we've seen in which our health and healthcare system is fractured. Now, if any of you work with individuals in vulnerable situations, such as those dealing with homelessness, we know it, because when you look at someone who's in a homeless situation, you can see where all the fractures are within our healthcare system and within the way that we support people with safety nets and social services. So a lot of the things that the ACA and other federal acts have gone to try and repair, and Senator Friedman talked about some of the amazing work she's been promoting, that's trying to address this, and the pandemic really highlighted them. One of the things that the pandemic highlighted is unsheltered individuals in Boston. Not next slide, but that's okay. Mayor Wu asked me, when she was elected, she asked me to help address what people were calling the humanitarian crisis at Mass and Cass. And because of my prior work, I agreed to join and help the administration in that work, really at a crisis situation. So what we're dealing with when we're looking at this is we're dealing with the intersecting issues of homelessness, substance use, mental health, and the adverse health outcomes that produces. So depending on what type of clinical work you're doing, you'll see some mix and overlap of all of these. But any of us in healthcare, when we have an individual who has these three trimorbidities, as we call them, there is immense medical health outcomes, expense to the system, and incredible burden to the individual that we see coming together in the individuals that then congregated at Mass and Cass. Next slide, please, if you can. Thank you. So I'm going to talk for a minute about what the crisis was and kind of encapsulate that for you, what the solution was, what the action was that was taken, and then talk a little bit about what's to be in the future. So first, the crisis. So what you've seen in the newspaper and people colloquially talk about as the Mass Cass neighborhood. So to be clear what that is, the Mass Cass area is the place where Massachusetts Avenue and Melania Cass Boulevard intersect. And that's just a little bit up the street from Boston Medical Center, if you're familiar with that. And it's that quarter-mile radius. And a crisis situation developed really during COVID. So there have every now and then in Boston, we have had people who sleep outside. And in fact, you know, when we do the counts, in the winter, it's anywhere from 200 to 300 people. In the summer, it's anywhere, it sometimes expands to 600 to 800. However, we have never really had tent encampments like they have in other cities, such as LA and San Francisco. And what started to happen, and by the way, through COVID, many other cities are seeing this, is an increase in the number of people living and inhabiting in tents. And there was a group of these individuals who congregated around this Mass Cass neighborhood, if you will. And as that happened really prior to COVID-19, we saw an increase because of fentanyl in people being unsheltered and outside related to their substance use. And then with COVID, as many services were suspended or decreased, people started to come to the area to the point where at various points this year, we had over 90 tents in that area. Now, it depends what you're comparing to. For Boston, that is an extremely high number. So it started with a few tents up to over 90 and hundreds of people in the area. Mayor Wu, when she was campaigning, she said everywhere that she went, people asked her what she would do about the Mass Cass area. And she prioritized addressing this as soon as she entered office. And I raise that because you've heard from both Senator Friedman and Dr. McDonough that, you know, politics and policy are really important to addressing the issues that we care about. And I give you that example to say a crisis, we all know crisis from COVID-19, but in this case, a crisis of what was happening in this tent encampment really led to the political attention that it received and a then ability to address the programming and policy things that needed to be addressed. Now, bring it back to the healthcare piece of it. There were multiple healthcare issues related to the individuals, several hundred individuals staying in that area. And these included substance use disorder, of course, homelessness, drug trafficking, exploitation and violence, especially of the women who were staying in that area, overdoses, both those that were reversed by naloxone, a reversal agent, and those that led to death. The effects of weather on health, including hypothermia, frostbite, heat-related illness, a grave exacerbation of chronic medical illnesses. You know, there were no toilets, there was no running water, access to foods that people need for certain medical conditions, ability to take something like Lasix because somebody would be going to the restroom all the time, all very difficult and challenging to do, leading to exacerbations of underlying chronic medical illnesses, as well as mental health issues. And other issues very specific to the location, like infestations and other infections, wounds that couldn't be cared for properly because of the conditions. So what we had here was we had a crisis of multiple individuals suffering deeply with medical, mental health, and addiction issues, and a community surrounding it saying the area is unsafe, there's increased crime, there's increased violence, and what are we as a city going to do about it? And I will say that there had been attempts before to address this problem. And many of those attempts, several of those attempts in the last few years failed. So when we were looking at this, we really wanted to take an approach that was different. And so the way we viewed this was to really go to the community and understand their needs. So a community first approach. Which, by the way, is something that COVID-19 really highlighted as well, to go to the community that you're trying to assist, because the best solutions come from understanding their needs and what they believe would be solutions to the issue. So a community first public health approach where the focus wasn't on let's remove these tents, but the focus was who are the people inside the tents and what is causing them to stay there and not go to the rest of our safety net system. And I viewed this as the tents as a symptom of the failure of our current health and healthcare system to provide what these individuals needed. Next slide, please. I really want to give you a sense of what we were facing. So as we began this work at the end of November, when the mayor was elected, the cold weather was coming. This is I spent a lot of time down in the Mass-Cass area as we were talking to individuals and planning what to do. And this is after one of the snowstorms. And you can see that, we helped individuals shovel out of their tents, but we had no idea. A lot of these individuals were using substances. We didn't know, what state they were in. We went tent to tent doing wellness and clinical checks on individuals. And if you look on the right-hand side, some of these tents were quite buried. These people living in tents at baseline is very challenging and is even more challenging in our New England winters. Many people were treated, as I mentioned, but to emphasize, for cold-related injuries. And in addition, there were many fire-related injuries and actually tents burning down because people were using all kinds of ways to create fire and stay warm. Next slide, please. So as I mentioned, we wanted to be data-driven and understand who are the people and what are their needs of the people staying in the tents. So in early December, we conducted the first of its kind tent survey looking at the individuals. And I'll just share some high level results so you can get a flavor as well of who the individuals were staying in the tents. So at the time, there were 77 tents. At the height, there were over 90. They were split between the two streets where we were seeing this activity. And there were a total of 145 occupants. Mind you, there were many more people that were around during the day, but the people who were actually sleeping in the area that we were focused on finding them a viable alternative, there was 145. And there were most of the tents had one or two individuals staying in them. Next slide, please. So looking at the demographics, there were 32% of the individuals staying in the tents were female. In terms of age, there was a wide variety, but I've been asked before, were there children in these tents? No, children were not in these tents. All were, again, this is self-reported age, 18 and over. And you could see they ranged in age, the majority from 25 to 44, but there were some older individuals as well. Next slide, please. We also looked at race ethnicity, and you can see here that 36% of the individuals staying in the tents reported to be white, non-Hispanic, 19% Black, non-Hispanic, 39% Hispanic or Latinx, and then a smaller amount that were multi-race. We also found that the majority of individuals, their primary language was English, but about 14% their primary language was Spanish. I will say that part of the reason for collecting these demographics were that we wanted to lead with a health equity lens. And what I mean by that is one of the lessons that I have learned, and I know many others have learned from COVID-19, is that health equity must be there from the start. So when we're making policies and programming, we must lead with health equity. And when we do it as an afterthought or an add-on, it's often too late to actually correct health equity issues. So from the beginning, we were documenting race, ethnicity, age, gender, other issues so that we could then track. And as we housed people, we followed on a daily basis whether our whether our placement in housing matched the demographics of the individuals we had in an effort to improve fairness and equity in our system. Next slide, please. So I already mentioned to you where the people were staying, roughly between the two streets, which I'll show you a map of in a minute. A lot of people wondered if individuals were from Boston or not. By self-report, about 22% were outside of Boston and the others from Boston. This has come up as an issue throughout these efforts, as when we build something as a city, we want to help as many people as we can, but we have had people come as they've heard about this program from other parts of the state, but also from other states. I personally have heard of individuals coming from Michigan, New Jersey, Arkansas, Rhode Island, and other states to be able to avail themselves to services in Boston. If you look on the right-hand side, the number of years living in tents, this is an important piece to really capture who we're talking about here. A lot of these individuals are chronically unhoused. So if you look, about 20% were unhoused for less than a year, but if you look at the rest, 6 to 10 years, 10%, the vast majority had been homeless for at least a year. And in thinking about housing opportunities and ways to help individuals get out of the tents, this was an important factor to take into account, that people had spent a long time living outside. Next slide, please. So we were really interested in understanding what access to healthcare individuals have. And I'll say that the ACA, many of the principles of the ACA were built on things that were done in Massachusetts long before they became federal. And one of them was really improving access to healthcare for all individuals, particularly homeless individuals. Before the ACA, it was changed that an individual who was homeless after a year could get on Medicaid. And that was important because prior to that, it was really based on your medical conditions. And it was overlooking the fact that we don't want people to be homeless long enough to get some of these medical conditions that I spoke about. We want to be able to be in preventive mode with the medical issues that come along with not having a home. So the important thing, though, is when you look at this group of individuals, who had a healthcare provider, there were lots of people coming to the prevents, providing services, but yet still, even with healthcare access in Massachusetts the way it is, only about half of the individuals staying in these tents had a regular medical doctor or access to a regular medical doctor. And I highlight that because as we think about improving access to healthcare, you see that it's very important, but it's the first step. Once we have access to healthcare, we have to make sure that that access is something that an individual can truly have access to through transportation, sick time off from work, ability to contact the clinic, ability to come during the hours that the individuals are available, and ability for these clinicians to be able to meet individuals where they are, which may not always be in the four walls of a clinical setting. Next slide, please. Looking at substance use, we found that 23% of respondents at the time were getting treatment for opioid use disorder. Very important for us, as we know there are treatments including methadone and Suboxone that are evidence-based and assist people in opioid use disorder. When you look at the type, you can see here that a small majority were on methadone and the others on some form of Suboxone of the individuals that we surveyed. This was interesting to us. If you look at current substances, this aligns with other work that we know from both Boston and Massachusetts. You'll see the high rate of crack cocaine use at 87%, opiates 76%, methamphetamines 20%, and then other. And you'll see that opioid use in this group, as it is throughout Boston and throughout Massachusetts, is a polysubstance use with, you can see here, majority of individuals using 2 or more substances. That's the table on the lower right. Next slide, please. And mental health, I know that many of you are in mental health fields or interested in mental health. So you can see that when we looked at access to mental health, only a small amount, 22%, had mental health providers who they were working with. Of that light blue area, the majority wanted somebody who could assist them with mental health. The percentages didn't follow through on this slide, but the majority wanted somebody that they could speak with. So there was a gap in ability to have mental health services. Next slide, please. So we defined the problem, and now we were looking for a solution. So the solution we thought of was these individuals that we were working to assist were unable to use the current shelter system, the current way to get on lists to be able to have access to housing, the current treatment system, the concurrence of active substance use did not comply with being able to be admitted to a hospital, sit in a clinic waiting room, follow the rules of a treatment system, of opioid use disorder treatment system and be able to do the paperwork needed for housing. So these individuals were pushed to this area of mass CAS, and we wanted the solution to fill in the gaps that we were seeing. So we came up with with 6 different sites that we then decided needed specific elements to be successful. And I'm going to talk about the sites in a second, but I want to show you some of the things that we thought were crucial to have in those. And that included psychiatric and mental health interventions and coordinated care with those interventions. Many people had seen somebody once or twice, or were seeing a psychiatrist in one place, a counselor in another, and really trying to coordinate that care. Substance use disorder, both medications and counseling and education, as well as I mentioned, the need to connect to medical care. And these 3 components, the 3 first bullets, are really important when we think about it from a healthcare point of view, because providing these individuals with those essential pieces of care that they all needed was crucial and important for them and life-saving. However, if you take a step back and you think about some of the things that my previous presenters showed you, things like healthcare costs. We know that some of the most expensive individuals within our healthcare system are individuals suffering from mental health issues, substance use, and then the medical issues that come with that. And to bring down those expenses, we have to make sure not only that individuals have access to those services, but they have access in a way that they're able to obtain those, and individuals who are trained in caring for them. But that's not all they needed. So those are the medical components, but they really needed intensive housing navigation, really transitions and aftercare planning so that they could move into permanent housing, and really increased connectivity across not only their healthcare services, but their housing services, their social supports, their ability to prevent relapses and follow harm reduction, such as having access to safe needles, having access to naloxone, having transportation, and then the basic needs that are part of health: food, housekeeping, laundry access. These things really put together the components of what we felt would make people successfully be able to come inside. And I want to pause here and look at this with you together, because if you look at these components, to me, these are essential health components. And maybe you don't think about access to food or access to housing as a health component. It's connected to the healthcare component, but part of a broader piece of health that we all need to stay healthy. And when Professor McDonough shared the cost of healthcare in the United States versus other countries, if you then look at what other countries spend on social services, the things at the bottom of my chart, you'll see that that spending far outweighs what we spend in the United States on those issues. And some of the things that made me personally very excited about Build Back Better and the components of it were, of course, the pieces that were healthcare specific, but also the parts that were going to improve health overall through other aspects and other sectors. And that included things like free preschool, childcare, making childcare more affordable, child tax credits, increasing affordable housing supplies, and focusing on childhood nutrition. And these are the pieces when we think about, I'm talking here about an intensive intervention that the city of Boston had to do, given what we were dealing with. And there's so many ways along the way of a journey. If you ever have the privilege of having patients who struggled with homelessness, if you talk to them about their journey, there's so many pieces where you can see prevention would have been better for them, but also more cost effective for our system to be able to do that. And you saw these same breaks and fissures come out in COVID-19 in terms of who was most susceptible, what kind of housing arrangements they had, what kind of jobs they had, what kind of access to materials in their own language they had, and so on. So a really important, takeaway for me that I hope you'll take from this is that it's very important to do the healthcare pieces of it, but there has to be attention to the overall health in any ways that we're helping, especially when we're thinking about it at a population level. Next slide, please. So I want to give you an example of some of the sites. So we said, okay, those are the sites we want to set up. They do not exist right now in Boston, and we want to set up these sites. so that we can move the individuals from the tents. So we set up 2 hotel sites. I'm showing you one of them here. This is the Envision Hotel located in Mission Hill, just down the street from the Jamaica Plain VA. And this was a hotel that was out of service, mostly related to recent changes in travel, that was going to be out of service for a while. And it has 40 beds. And those rooms were converted into a program where we could provide the shelter and the housing, but also access to those other pieces that I told you. The other hotel that we were able to bring online was the Roundhouse Hotel. And that is a hotel right down the street from Boston Medical Center in the Mass Cass area. One thing I want to say as I talk about these sites is Senator Friedman spoke about a very important issue around stigma and some of the work she's doing to put more towards stigma. And I can tell you that one of the most important things in developing these new programs that we needed was NIMBYism and people not wanting these programs in their neighborhoods and not wanting to have quote unquote mass cast move to their neighborhoods. And that will remain a struggle. And I hope at some of the stigma work will help people understand who the individuals are at a more human level of who their individuals are we're caring for, and also to think about our collective responsibility to one another and what individual sacrifices we're willing to make in that realm. And COVID-19 certainly brought up those issues as well. The Envision Hotel and the Roundhouse Hotel were by far our most sought after sites, as they allowed for some privacy and some ability to still access the programs that I mentioned. Next slide, please. So we set up 3 shelter-based sites. Now you may say, aren't there already shelters all throughout Boston? What we did is we set up harm reduction low threshold shelters. And what I'm showing you here is the Pine Street Inn shelter that was set up on the Shattuck campus. If any of you have been to a shelter, and I urge you to at least please visit one so you can see the conditions there. These beds are much more spaced out. They usually don't have these privacy walls, and they're oftentimes bunk beds as well. So this is much less crowded. And the other things we set up and communal space as well that you'll see on the right. The other thing that we set up is we set up ability for someone to come in and out as they need to. So many of the individuals staying in the tent encampments are actively using fentanyl. Fentanyl is shorter acting than other opioids and requires individuals who are addicted to it to use more frequently. And staying inside a shelter for 8 or 10 hours is not something that they feel they can do. So this setup allows for people to come in and out of the shelters, and they come in and out of the shelters, and they also have a harm reductionists, so people who are there monitoring, as well as nurses. So they have increased medical care while they're here and intensive housing support. And this shelter that I'm showing you here, the Pine Street Inn one, outside of the shelter, there are amnesty lockers where individuals can leave anything that they are not allowed to bring into the shelter, including drugs, drug paraphernalia, or anything else, so that they feel like they can come into the shelter. So it's really about meeting people where they are, bringing them into a safe indoor space, and then, of course, when they're there, approaching them about treatment options and taking care of their other medical needs and helping them to reintegrate into society. So Pine Street Inn was one shelter that we set up. The other shelter-based locations that we set up were at our city-owned shelters, and that includes the Woods Mullen, where we set up a women's shelter. This Pine Street Inn could hold 30, the women's shelter at Woods Mullen could hold 25, and then another 25 at the men's shelter at 112 Southampton. And all of those shelters were set up as low threshold, ability to come in and out, less crowding, and intensive management of the issues that they have. I happened to glance at the chat and see that there was a question about Worcester and Springfield. I'm focusing here on Boston, but I will let you know that I've spoken to the individuals in Worcester and in Springfield. In Springfield, very interestingly, they have no tents, even through COVID, and they have a model where they have outreach, which I'll talk about in a little while, that is conducted by public health and public safety city where they go out together and address tents as they come up to talk to individuals about services. However, they do have tents in surrounding areas, especially in wooded surrounding areas. Next slide, please. So the third really unique model that I want to show you is the cottages or tiny houses. You may have heard of these. These are temporary units that are set up. On the right, you can see what they look like on the outside, and on the left, you can see what they look like inside. I'm showing you a picture of a smaller one, but they're still able to fit 2 beds, or you can flip one up for it to be single occupancy. And these were set up and really spearheaded by the state government and in collaboration with the city to allow for us in Massachusetts to try for the first time these tiny temporary houses. Same concept, providing the services, allowing people to have a stay, a shorter stay there. You know, they were envisioned to be 90+ days. When they've put them into practice, they've seen, depending on the housing market where you are, and you know the housing market here in Boston is very tight, they could be used for longer times as well. Insulated, heated, has a communal area as well, has regular checks for harm reduction, and 24/7 nursing as well. So those are some of the examples. So to summarize for you where we are so far, understood this to be a crisis. There was political, there was a time where political action could be taken, said, let's look at this through a public health approach, focus on the individuals, collected the data to understand who we were dealing with, worked with a solution that would address what the individuals said they aren't able to get in our current system, and then quickly stood up these sites. All 6 sites were able to, some degree, be set up by January 12th, which was the deadline we set for ourselves. We were really racing against time in doing this work because we were very worried about the cold weather, and we had not in Boston had that kind of encampment with tents through a winter. So we really quickly worked with the providers. The providers who worked with us, with the city of Boston and the state, were unbelievable in their desire to assist and their capacity to quickly stand up these services, seeing the need. For some of the providers, this had been work that they knew needed to be done for years. They knew it was a gap in what we were providing, so they were excited to be able to provide it with us. I will say back to I was so happy to see in Senator Friedman's discussion the talk about workforce, which I'm sure you've spoken about in other places as well. One of there were 2 things that kept us from, which slowed us down in terms of opening sites and kept us from opening more. One was the issue that I said to you, was explained earlier about NIMBYism and not in my backyard, and people not wanting any of these programs in their communities. And the second was workforce. There is a dire shortage of behavioral health workforce, as well as shelter and social service-based outreach workforce. So we also, I told you we did the survey in the beginning of December. We launched the tent by tent engagement to help people find which one of these opportunities would be good for them on December 15th. And we then were able to give people those opportunities through January 12th. And as you all know all too well, that was also in the middle of our Omicron surge. So staffing and being able to staff up and provide the staff we need was an incredible challenge during this time. Next slide, please. So for the final piece, I want to talk to you about action. So how, you know, at it may be of interest to you at a city government level, you know, how do we move something like that to say, okay, we have these spaces, and now we want to take the individuals who are in these tents and voluntarily offer them these services. And really, it takes an unbelievable coordinated effort across city government. So that includes Public Works Department, who does sanitation, the Homeless Services Bureau, which sits in the Public Health Department of Boston, which is called the Boston Public Health Commission, the Fire Department, the Police Department, both the regular police department and their street outreach unit, Emergency Medical Services, so EMS, the Mayor's Office of Housing, the Office of Recovery Services, which sits within the Boston Public Health Commission, inspectional services for the city, the public schools, our neighborhood services office, our urban mechanics, and actually many others as well. So we had, during the time that we were planning for this, we had multiple time a day meetings of coordination and cooperation. And I must say that it's, people say, well, how come past attempts have failed and, the impossible was accomplished this time? And, a lot of it is about having the leadership support to prioritize this issue, and then having cooperation and coordination among our different departments within the city and our provider community who really came forward to provide these services. And, a lot of the skills are skills we learn as clinicians of being able to listen to individuals, understand their point of view, and then find compromises as needed. Next slide, please. So I wanted to show you this map is something we use just so you get a tangible sense of some of the tools we use. We created this map, and you can see the two areas up on the top at around 12 o'clock is the Atkinson Street area, and that's right outside of an engagement center for unsheltered individuals and right outside of the men's shelter. Right in that area, there are also two methadone clinics, and to the left at about 11 o'clock or so is Boston Medical Center and Boston Healthcare for the Homeless. And you'll see down below at about 5 o'clock is the other area, Newmarket Square, which if you've ever gone down there, it's an extremely industrialized area with a lot of large manufacturers. So we really had the business community also ready to help us, but also asking for these tents to not be there anymore so that they could go about their business. A lot of heavy machinery and equipment there as well, which was dangerous to the people staying in the tents. Next slide, please. So we went tent to tent, and first from December 15th to January 12th, we offered individuals housing. Of that 145, about 105 initially accepted housing. And you can see that the day of the last day when we were offering services on January 12th, this is the beginning of the day. And then after all of the tents were cleared that were in that area. But much more importantly, every individual was offered a viable alternative. Many of them took them. Some of them didn't take it on that day, but everybody knew and took down their tents. And many individuals came back to take the services later. We kept a list of those individuals, and we actually have a waiting list now of about 120 additional individuals because people were added to the list who were in treatment programs or incarcerated or at one of the local hospitals at the time that we did the count. So there's an incredible need. We currently, in those 6 sites I showed you, have 175 individuals who are staying there. And the most important thing to me about that is that people are staying. So these are, this has been all of my professional work. I've worked with individuals suffering from homelessness, and it's very challenging for people who are chronically outside, especially with the comorbidities we spoke to be able to stay inside. And it's incredible that our data shows us that the vast majority of individuals have stayed. We're 2 months out. A handful of people have been moved on to permanent supportive housing, but all of them are working on housing opportunities, and the majority have stayed on average 80%, but within the hotels, it's upwards of 95, 96%. So it's a real signal that this kind of programming was a gap. When we provided it with a public health focused on the individuals with compassion and empathy, they were able to come out of the situations in the tents and really work towards where their next step would be to improve their health and to improve the community's health, where we don't have this kind of a tent community anymore. I must say, I forgot to tell you in the survey part, this is very important to me, I had heard that we would not be able to move individuals because individuals, quote unquote, wanted to be in those situations. And I can tell you that I spoke to many people there and nobody wanted to be in this situation. I went into, on the last day, we checked each and every tent. I went into the tents. There were situations where you would not imagine that people were living in those situations in a place like Boston, Massachusetts, in the United States. And they were dirty, they were unsafe. There was the violence, exacerbation of medical issues. And we're just thrilled to have those individuals in these temporary housing systems that we have set up. And I have interviewed people who stay in these, had many conversations with them, and with all the suggestions they give us for change, which are all really important, it's unbelievable to hear people talk about how transformational these spaces have been for them. People talking about the first time in their life they feel hopeful, people being able to access care, starting on methadone, starting housing searches, reconnecting with families and loved ones. And to me, this is really what it means to truly provide opportunities in health to all of us, and do that in an equitable way, and build back better and learn from our experiences. My last slide, if you can go to that one, please, is just some closing thoughts, things I want to make sure to mention to you. In addressing any of these issues, it's really important to engage stakeholders. We found this with COVID-19. It's equally important with these kinds of projects where there were people who were on all sides of what they thought needed to be done related to the encampments, including business members, including individuals from the community who were angry that the tents were there with their with the debris, the violence and everything, the noise that came with them. And then there were the people with the lived experience and the providers, faith-based organizations, business leaders, and we all really came together and were engaged in this work. Any sustainable solution to me really needs to incorporate all of those aspects. Another piece of work that we're doing right now is on sustaining this. I've been involved with so many projects over time that are grant funded or temporary or considered pilots. And to me, we have identified a gap in our current system for serving individuals who are unsheltered and unsheltered due to having an active substance use issue. And we are looking for ways to sustain these programs and to find ways to have them continue to work because of the results that we're seeing, the early results. And we're looking to do long-term transformational work. We're working on that now to understand what we can do to really transform the way we think about homelessness. How does it connect to all these other pieces of health that I've spoken about, the pieces of healthcare access that Dr. McDonough has talked about, the pieces of reform that are happening that Senator Friedman reports about. These are the individuals who need those services the most and don't always have a voice. So as part of a policy agenda, it's thinking about how, when we make policies, we make sure that we think about the repercussions and the impact on everybody, including those who often don't have a voice at political tables. And as healthcare workers, I often get asked, what can I do? I don't work at a systems level. There's so much advocacy that we as healthcare clinicians can do, whether it's in the clinic room with our patients, whether it's how our healthcare system is run, whether it's how we advocate for what should we be taught as students, whether it's ways that Senator Friedman suggested in contacting those who are making important decisions and understanding, people love understanding how individuals are impacted in positive and negative ways by the policies and changes we had. So I urge you to speak up, use the platforms we have to be able to advocate for our patients and push for fairness and justice in health. With that, I will pause and hand it back over to Marianne. Thanks for the time.
Thank you so much. It was just amazing to hear boots on the ground and what that means. And, we're going to enter our question and answer period now. And so people should put their questions addressed to Kayla Bavin into the chat. And I will be asking some of the questions as I get them, and I have a few now. So one is actually for Dr. Bharel, and it knits together with the other presenters. To what extent have resources come down from the federal government to the state government to the city government to enable you to do some of these things? In other words, one of the successes the Biden administration has had is the American Rescue Plan. The Build Back Better plan hasn't passed yet, but to what extent have those resources and that commitment on the federal and state level helped the city be able to do some of these things?
A great question, and no, to put this kind of effort forward and to continue it, no city can do this alone. We have had unbelievable assistance from our state partners and have been able to use federal ARPA funds, as well as the state, including EHS, being able to pitch in funds to do this emergency response, and are working very closely with both to understand how we can continue and enhance this work as we move forward. So it's definitely a collaborative effort. And I will say even in creative ways, using public-private partnerships has been very helpful as well, including our the business associations in the area, even volunteering to do things such as a peer work program and hiring some of the individuals from the tent areas. So really creatively trying to help us improve the services provided.
Okay, thank you. This is a question for Dr. McDonough. I think this is a good question. With regards to the performance measures for the 11 countries, how do we explain that the US has a great score for care process, but an 11 for outcomes? You want to take a shot at that?
Yeah, it's a great question. Thank you. And I could talk for hours about the Commonwealth Fund study. So care process is, and it varies survey to survey. This is the 7th time they've done this survey, but care process has always been the one where the United States does better than on the other measures. And that relates to what so many people here in the audience do, the care that's delivered in facilities, in healthcare institutions and so forth. But healthcare outcomes deals with the outcomes, a lot of it is the population health outcomes. So that's where the staggering degree of obesity in the United States stands out. That's where so many of the other population health outcomes come into play, like, for example, the epidemic of gun violence that is simply unknown elsewhere around the world and has staggering costs and implications. The reality that in the United States in the last 5 years, we've had 4 years where life expectancy in the United States has gone down. That's prior to the last 5 or 6 years or so. The notion that life expectancy would go down in the United States was a bit like claiming that water would run uphill. It just couldn't happen. And yet this is our reality right now. So, and the truth is that a lot of these major gigantic problems like obesity and gun violence and other environmental contamination and poisoning, these are not the fault of doctors and physicians. Doctors and physicians did not create the obesity epidemic. It's other things in American society that are creating these poor outcomes. And so, so that's why I think that there is, over the past 10 years, a growing and sophisticated effort to get at population health improvement, the social determinants of health, like housing and nutrition and safe neighborhoods and so forth. And that is increasingly where, if we want to turn around America's really sorry performance in terms of how well our health system serves us, we have to look outside of the medical space to really achieve the kind of gains, including the incredible work that Monica Bharel has been doing.
Great, thank you. Thank you for your response. I have a question for Senator Friedman. I think it was sent to everyone, so you might have already seen it, but this person says, I'm personally aware of 2 physicians and 1 oral surgeon who are not able to practice in the US because they're immigrants and were trained in foreign countries. They have jobs way below their capabilities and can't afford to pay in the recertification programs available. And so the healthcare system loses their talent. Is there any effort to help people like this to recertify so they can contribute to the healthcare system and use their education experience? And this person also says, thank you for your good legislative work.
Thank you. Actually, there is. I think we had a short-term commission to study the certification of foreign trained healthcare workers. And I know that believe they're coming out with a recommendation fairly quickly. We have a bit of a problem in this state, and it's sort of the opposite of NIMBY. It's the only in my backyard. And we tend to think, and we have incredible healthcare institutions in the Commonwealth. We sometimes tend to think that if you weren't, trained here, if you didn't come from here, if you didn't get your health training here, that somehow it can't quite be as good. And I think that's something that we absolutely have to get over. And the other piece that we need to address is the long wait of many of our potential providers in getting licensed. And this is across the board. It's mental health counselors, it's licensed social workers, it's doctors from another state, it's nurses, it's advanced nurses, it's across the board. And so we're really looking at what changes we can do basically it's at the executive branch level where this licensing happens. What can we do and what can we require that would speed up this this issue? Because it is an issue, and there are a lot of people that would love to come and work here. They're highly qualified, and we should be paying attention to them.
Anybody else in the panel have any comments about that? One issue that we've been talking about at Regis College is the difficulty in getting preceptors for many of our nurse practitioner students, including psych nurse practitioners. And that is really probably holding us back from having as many students who are as interested as they are in being part of a program and becoming NPs. So I think that that's another barrier to the supply of advanced practice nurses and probably other professionals as well. And especially COVID has exacerbated that, but it was always difficult, and it has become much more difficult.
Yeah, I mean, we have this sort of notion, I've noticed, and especially I've noticed it very much in COVID, which is we will give you more money to work harder. And people can't work any harder than they're working, right? We need to pay you enough to do your job. And I think if we start to really look at those rates, especially when you're adding in the mental health field, it is especially true that if we can, for instance, carve out time for preceptors, not assume that a supervisor can do their job all day and then go supervise people, right? That we make it part of their job, that we compensate people appropriately, I think, and that we really look at our regulations of what we require and whether those regulations are, enhance the care that people get, that are meaningful that are meaningful and needed to get good practitioners. We can move some of this bottleneck and move some of these barriers for people. We have just some rules and regulations besides what we pay people, especially in mental health. We have all these rules and regulations that I'm not even sure make any sense. And I don't think they've been looked at. And maybe they're there for protections of the status quo, but it's really our job. And I think it's our job as legislators to look at that and see what is it that we need to do so that we can open up these pipelines.
Okay, thank you.
Just to add on another component to that, part of the staffing is also the individuals, the professional staffing. I agree with everything Senator Friedman said, but in addition to that, there's the other support staff who help, for example, and when we build these new wonderful community-based behavioral health centers, there's a lot of support staff. When we look at building the programs that I mentioned to you, the pay for an entry-level person in, say, case management or harm reductionist or navigation is, people can easily go to a I was trying to think of a way not to say Amazon, but I don't know how else to say it other than saying
You
the
can
word.
say McDonald's at this point.
Yeah. The pay there is, if you max pay you're offering someone is $18 an hour for really beautiful, but really, really hard work, right? And that you can go and do packing at Amazon. It's hard to get people into these spaces that the whole structure needs to work from the professionals and everybody else who are part of it.
Okay, thank you. This is for Dr. McDonough. Can you summarize why universal healthcare would not work for the US?
Oh, I would not do that. I think it could work. And I think that every other advanced country on the nation has proven that it can work. We have come further towards it over the past 12 years or so than we ever have. And we're still a long way off. We still have about, give or take, about 30 million uninsured out of about 330 million people. So about 8 to 9%. And it is achievable if there is the political will to achieve it and the resources. What the person, I'm gonna just interpret maybe what the person is saying, could we get a single payer system like Canada or the UK or some other nations, and why not? And we clearly could, it would be technically possible, but our political system has just proven unable to deliver on that guarantee, that promise, that ability to do something that would make a lot of sense. And there's a lot of reasons for that, but it hasn't gotten easier to get to that place. It's actually gotten harder with the changes in American society over the past years. Even the program like Medicare that people look at as sort of the pure public entity, as I mentioned, about nearly half of the people in the Medicare program right now participate in the program through a private health insurance company, through the Medicare Advantage Part C, part of Medicare. So it's getting more and more difficult as the system gets more and more fractured, and as more and more money flows into it, because the stakes are then so much higher for all of the payers as it goes forward. So yes, it could be done, but it's a matter of political will that thus far the nation has not proved capable of surmounting.
It sounds like what you're saying is that you don't have to have Medicare for all to get universal health care. I think people conflate the two, but is that what you're saying?
Yeah, absolutely. I mean, a lot of people, to the extent that they know any other country's health system, know about Canada, where they have a kind of a single payer up there. And all of them are different, but all of those countries that were on the Commonwealth Fund chart, most of them don't have a single payer. They have some kind of a multiple payer system, and they make it work. But there's a lot of people have this idea that it's Canada or what we have uncharitably known as bust. It's sort of Canada or bust, and that's not true. There's one system that I think is most like the US where we could move in that direction would be a system like Germany's, which has great public satisfaction, universal coverage, a lot of freedom of choice, and works very well, and they continue to move toward improving it. So there are multiple ways to get there, and it doesn't have to just be the Canadian or British single payer route.
I was personally surprised to see Canada rated number 10 on that chart. We're at number 11, but Canada was rated pretty lowly too.
Yeah, I point that out to my students all the time. Many of them get up every day, get out of bed and kneel next to their bed and say a prayer to the shrine of the perpetual Canadian single payer plan. And I have to remind them that at least in the Commonwealth Fund study, Canada only looks good in comparison to the United States. Many other systems do quite arguably much better than Canada does, and they don't have a single payer.
Thank you. Another question, this is, I think, a good one and timely, that Wi-Fi access, which is now becoming more critical for healthcare access. And what is the state doing about that? Or what are we doing about that? In other words, making sure that there are even some places in Massachusetts One person said that they had a relative that didn't have Wi-Fi access where they were. Anybody want to take a stab at that? Senator Friedman, I know you've been involved in telehealth.
So if I had any kind of memory, I would be able to tell you specifically where it is. But I know that in the last, I believe, the economic development bill we did, there was money and focus on expanding Wi-Fi. What's really interesting, I would note, is that we've all been focused on the rural and Western Massachusetts areas where there's really is limited reception. And it's why in the telehealth bill, we were so adamant to include audio, because you can't, you need to give people access to everything, access to all technologies to use telehealth. But what was so striking to me was that people in downtown Boston couldn't get Wi-Fi. When you look at what happened with all the kids who were in the Boston public schools, and when they would go to do remote learning, they were sitting in parking lots. They were, at the library. That we really have to look at our infrastructure. But I want to remind people that part of the issues that we have is most people and a lot of constituents don't like to wait for the outcome of something. And investments like Wi-Fi, technology investments, infrastructure investments, things that people really depend on, take a long time to implement. Not because people are lazy or because they don't want it, it's because they're complicated and it takes a long time to build Wi-Fi towers and make sure that there's access in a very old city to these kinds of new technologies. So part of this is to get residents and people to understand that these investments, these long-term investments, are critical to ensuring that we can maintain the quality of life that we all have come to expect. So yes, the state is looking at it, and it would be great for people to understand that this takes a while, and the longer you put it off, the longer it takes. So it's especially true in healthcare, where you need to work on things, you need to make changes. You're not going to see those savings or those outcomes tomorrow. They're going to take a while. They're going to take years. But we have to do them now or we'll never see those changes.
That sort of brings me to a thought about Dr. Bharel and some of the people that you've dealt with in Mass and Cass and others, the underserved populations. What is the situation with their internet access or telehealth access, or is that really even an issue at this point for them? Or are their needs so extreme at this point that that's really not something that is on the top of the priority list?
So a few thoughts on that. So one, the digital divide really does have an implication on healthcare and equity in healthcare. So one of the things, so just taking a step back, one of the things that Senator Friedman, you mentioned about the audio, that was such an important part, because actually we saw that people's use of healthcare in some settings actually increased with this capacity to do audio when people couldn't do video. But even doing video where people had access to Wi-Fi, it's sometimes in people and groups that you didn't expect, increased ability to be compliant with visits, because it was less need for finding, affordable childcare so you can go to the meeting. It was less need to take, you could do it on your lunch break at work as opposed to having to take half a day off. So, there are implications for continuing telehealth that actually can improve some of the equity issues that we see. And by the way, especially in behavioral health, we had huge success with people being able to safely access methadone by using telehealth, as well as buprenorphine and starting meds, as opposed to having to come into centers. And same thing for mental health counseling. So, it kind of all ties into what we're speaking about. As to people who were staying in the tents, it was a variety. Some people did have phones, not as many smartphones. And the health that we brought to them while they were in the tents really had to be, physically bringing it there as opposed to the telehealth. They can access some telehealth services while they're in these sick sites. They sometimes are able to obtain phones that are mostly flip phones. There is a program through the city to help share Chrome devices so that individuals can have access to them to do, say, some of these telehealth or to do, job searching, some kind of training programs. So we are pushing that out to try and help with that. But the digital divide has consequences in ways I think we don't always imagine.
Right. Thank you. We have an observation and kind of a question here, which is sort of interesting. And Dr. Bharel, you referred to people coming in from out of state or, out of Boston, out of state possibly, to avail themselves of some of the better services in the city. And that sounds like Boston did the right thing and didn't turn people away. But is this something that we should be worried about long term? What do we do about this?
It depends what you mean by worry. So, what we need is really a national approach to thinking about how do we address harm reduction? How do we provide unsheltered individuals with the services that they need? How do we improve, take what Senator Friedman is doing here and take it to the national level? How do we improve care in the ways that Build Back does and some of the other things that Professor McDonough mentioned. So, it depends what you mean by is it good. Now, when we're with Boston, we do talk regularly with our partners at the state level about how this can be in Massachusetts. When speaking to our colleagues from around the country, it is in other cities who have done similar kinds of work. It is one of the big issues that is challenging because you don't want to not give somebody services, but if you have services that are, seen as better than surrounding areas, it can be problematic. It's unsolved.
Would all of the panelists agree with the idea that, I don't want to sound like a Pollyanna, but in Massachusetts, it seems like compared to a lot of states, a lot of the stakeholders in Massachusetts have some shared values that really means that they've been able to work very effectively together. Mass health reform, working together in the city of Boston to do what you just accomplished, that I think there are many examples of that. And are we less partisan in our thinking and more sort of, all sort of rowing in the same direction or a similar direction? And how has that helped? Anybody can comment.
Senator, do you want to go first?
Well, we are definitely less partisan in terms of our political, traditional Democrat and Republican, I think, at least certainly in the Senate. And certainly in this administration, we have just an extraordinary leader in our Secretary of Health and Human Services, which oversees all of these agencies that we're talking about. The issue to me, though, is not a partisan issue. It's an issue and where I see things, and actually Dr. Bharel referred to it with NIMBY, right? We're all really great in theory, right? But in practice, that's where I think things break down probably like they do in every other part of the country, right? I mean, in order to make the changes that we need to make our healthcare system saner, more accessible, more equitable, everybody's going to have to put skin in the game. And that means pharmaceutical companies. It means pharmacy benefit managers. It means providers. It means health. It means hospitals. It means universities. And what I see is we do have essentially a set of very common values in the way we in Massachusetts look at what we should be doing and how to treat people. I think we do. But when the rubber meets the road, that's where I think it's turning those values, those beliefs into actual action, right? So if you care about people getting housing, you can't say people can get housing everywhere, but in my town, right? If you really care about bringing down the costs of pharmaceuticals, you can't just measure how much revenue you've made and only listen to your shareholders. So I think that's kind of where we are in better shape than in a lot of places. And I love this state and I wouldn't move anywhere else. But okay, we can pat ourselves on the back for about 15 nanoseconds. Then we got to do the hard work. And I think that's where the differences come, not in Democrats and Republicans so much. That's my thought.
Okay.
I perceive that in states where the proportions of Republicans and Democrats are much closer, there's a lot more at stake in the partisan competition, and so it becomes much more combative, I believe. In the Massachusetts House and Senate, there are so few Republicans that they almost qualify for cult group status. There are just not that many of them, and they have a hard time just keeping up with all the duties that they have to manage because they don't have that many folks. And I think that tends to be reflected in some states that are just overwhelmingly Republican. There's not a lot of big fighting because there's not enough people to have it be a fight. But I think there are some things I've noticed, and this isn't just, I have a health policy friend who has done a lot of work in New York State and in Massachusetts, and perceives a huge cultural difference between, and that in Massachusetts, coming up here is kind of a joyful thing for them to do because there's just a lot less bare knuckle fighting among the different constituencies and stakeholders that they perceive, even in a place like New York, which is again dominated by Democrats. So there's something, and I think part of it is, we still do have largely a state healthcare infrastructure that is not profit, and in a way that you don't see in most other states. And while still nonprofits can be as avaricious as for-profits, for sure, and we see evidence of that here, there's also something different, that they're not looking over their shoulders at their shareholders and how satisfied they are with the financial returns. And that's just, I think that is a difference that makes Massachusetts somewhat unique.
Any other thoughts?
Well, I would just like to point out that I think the biggest change in healthcare that I see at a kind of nonprofit profit level is the introduction of all of the hedge funds and profit companies that are coming into Massachusetts. I mean, Atrius was our largest physician group, and it is now owned, going up the ladder, by United Health. And so I hear what you're saying, Dr. McDonough, but I think it is one of the most worrisome things that is going on in healthcare in Massachusetts right now. Is I don't understand how a hedge fund who buys, urgent care or buys a physician practice can just shed its fundamental reason for being, which is to make money. You got to help me here. So I'm very concerned about that in Massachusetts, and it's being done very quietly.
Yeah. This is going on all over the country, Senator, and other parts of the country are much further ahead. And the term of art, I think, is not so much the hedge funds as private equity.
I'm sorry, you're right. And you're right. I should call it private equity.
It is the invasion of private equity into every corner and crevice of the healthcare system all over the country, buying it up, not to produce better health, but because financiers see significant financial opportunities from milking businesses dry. They buy it on the cheap, mostly with borrowed money. They lather debt all over these institutions and organizations they take over. They hold on to them for 5 or 7 years and then look for someone to sell it to who wants to come in and make their own money out of the same piece. And it's an alarming process that's been going on for 40 years now and getting worse.
Just to connect that to some of the, healthcare worker things, as healthcare feels like the way you've described it as a commodity, that then impacts the people working in healthcare and their ability to go above and beyond, to do things that are the joy of practicing healthcare. And a lot of that is leading to some of these, the burnout. COVID put a major pandemic on top of that, right? That the burnout, people retiring earlier, is feeling like wedges in a system as opposed to really having those beautiful relationships that we have with patients. So, I think just one other comment on Massachusetts, which, I must applaud the people of Massachusetts in the way that every single person, did their part during the pandemic is really something striking and amazing. And when you talk about the sacrifices people made in name of the common good, it's been really amazing to see, especially comparing it to other places. I think that this is not all by accident, though. I think that Massachusetts as a Commonwealth has invested in things that make this possible, like amazing investments in public health, amazing desire to make healthcare accessible, right? Investments in education that helps everybody then kind of come around to these values. So I think it has been conscious work that has helped that, and you could see it during the pandemic. But that said, there's lots of work to do, and we have a lot of thinking in this Build Back Better mode of, what do we as a society, whether it's Massachusetts or bigger or smaller, want to provide people as a basic common good? Is it really healthcare? Is it really overall health? Is it housing? Right? And I think some of those questions are unanswered if you really dig into them at a personal level.
Well, that's a good note to end on. And I really, on behalf of Regis, want to thank everybody here because, I think you've all talked about at the various levels how looking at the social determinants of health, integrating behavioral health, how this really needs to be part of building back better and the future of healthcare. Maybe some of those other trends are happening with private equity, et cetera, but that we have to keep our eyes on this bigger view of what healthcare is and how to deliver it in a granular level, which we also heard about with the city of Boston. So thank you so much, everyone. And for those of you who need to make out your evaluation, I hope you will do that. It's going to be in the chat. And thank you to our speakers again, and have a good night.